Hi everyone, this is a video lecture for your special considerations in labor management. The first thing I'd like to talk to you about is dysfunctional labor. And that is one of the reasons I've talked about since the beginning of the semester how important it is for you to understand what normal labor is so that you can understand what abnormal labor is. So when we talk about dysfunctional labor or dystocia in labor, sometimes these terms are used interchangeably. They are it is when a labor doesn't progress as fast as it normally should be. Okay, so there's a lot of reasons. It's a leading indicator for a primary C-section. It usually, obviously, it's usually in the active phase where it's diagnosed as like either failure to progress or failure to descend. Factors associated with this are epidurals, multiple gestation, hydramnios, which is a lot of fluid, the baby in that posterior, that occiput posterior position, short maternal stature, like moms that are less than 5 foot tall, a big baby, to name just a few. Now, dystocia can result from problems with the expulsive forces, meaning the P's. So we talk about powers, whether too much or too little. The uterus contracts dysfunctionally. Too much can place a baby in danger. As we said, the biggest stress on a fetus is contraction. So therefore, if they're contracting too much, they're not having that rest periods and they're going to have those decelerations in the fetal heart rate. Too little is ineffective contractions, where you're not contracting, or you're not bringing that baby down. The uterus isn't contracting effectively. It may contract here, it might contract here. So there's something going on with the uterus, and sometimes that happens because of too much Pitocin. A precipitous labor is when the uterus contracts so much and so hard that a birth happens really quickly. There could be a problem with the passenger or the position or the passageway. There could be problems with the pelvis. There could be problems with the way the baby is. Remember how we talked about the best position for a baby to be is in that flex position. So if it's in any other position, that's going to inhibit the normal labor process. Stress plays a huge role, as we mentioned in class. And we're going to talk about a lot of these in the next few minutes as I go through your PowerPoint. All right. So when we talk about hypertonic, so hypertonic, think about what the word is. It's too much. Okay. This is a problem with the powers. So basically what this happens is onset of a normal labor pattern often occurs in many women within like 4 to 6 hours. So what happens with this is these moms come in and they are contracting so much, and it usually happens like in the latent phase of labor. And moms have been up all night and they're contracting like every minute and a half. And basically, what this does is moms get exhausted. The contractions are painful, but the cervix does not dilate. So it's really unfortunate because the uterus is not relaxing effectively, and ultimately it could cause like hypoxia because this baby's not getting all of its oxygen and nutrients. So basically it decreases poor placental perfusion, which can decrease oxygen to the baby. A lot of times what we do for these kids is that these moms, is what we do is we like kind of like we put them on the monitor, and we can see that the contractions are kind of crazy. We look at her strip, and basically what we can do is we can hydrate her to kind of dampen out the contractions a little bit. So with an IV fluid, and oftentimes we're going to give her pain management via her IV, which is morphine is usually is the standard. 10 milligrams of morphine, 5 milligrams usually IM, 5 milligrams usually IV push, and moms just kind of like are able to rest finally. And now, does this happen every single time? Absolutely not. But a lot of times what happens is they get a couple hours of sleep where they haven't slept in who knows how many hours, or they relax enough that their cervix dilates and they get out of that latent phase into active phase of labor. So we see this a lot with anxious first-time moms. And again, it's mostly in the latent phase of labor. So anything that you can help to relax that mom is going to be a benefit. Hypotonic, hypo means another problem with the powers. Excuse me. But often this is you're progressing in labor, everything's going good, you're in the active stage of labor, and all of a sudden your contractions just go, they just stop for whatever reason. Hypotonic is more common than hypertonic. Basically, what we do for this is a lot of times why this happens is maybe the baby has gotten to a point where it's not coming down anymore. So we call that CPD, is cephalopelvic disproportion, meaning that baby's not going to fit. Sometimes if you have more than one baby inside where the uterus is contracting in all different ways, and it's just not adequately effective is what I'm trying to say. Too much pain medication or early pain medication sometimes stops this. The major risk is hemorrhage because the uterus doesn't contract. So we start Pitocin to get her to contract, to get her to delivery, and then what happens afterwards is the uterus becomes atonic, or what we call atony, which is the number one reason for a postpartum hemorrhage. So some of the things that we can do for this patient is we can break their water if their cervix is ripe enough, which usually it is in the active phase of labor, and start Pitocin to get her contractions a little bit closer together to hopefully bring this baby down and to dilate the cervix. Okay, so that is hypotonic. Now, sometimes we have problems with the passageway. Well, whether there's a full bladder, so that's really important. Like if somebody has an epidural, that we're looking at that. If they've had any type of surgery on their cervix, sometimes there's scar tissue that happens there, or the CPD, the cephalopelvic disproportion. You know, you can start to see that because remember the ischiospines, which is the narrowest part of that pelvic outlet. So if the head is coming down, and then the skull is kind of just there, but all of it is just molding coming down, that gives us an idea that maybe this baby is not going to fit after it's been like that for quite some time with effective contractions. So that's why we kind of mentioned that dystocia in labor is one of the number one indicators of why we would do a C-section. Problems with the psych, it's just stress hormones play such a big role. Your support circle is really important. Past experiences, we've talked about this already this semester, but all of that plays a big role in how a woman is going to handle her labor. So when we talk about passenger dysfunction, anomalies is a big one. Any type of like gross ascites, a large tumor, a baby that has an open neural tube, those can cause problems with measurements and the baby coming through vaginally. Any position other than that anterior position increases the percentage of dystocia, because when we talk about the cardinal movements like that flexion, descent, they all have to occur in order to make the most room for delivery. The occiput posterior is pretty common. Sometimes we call it persistent occiput posterior. Just remember posterior, okay? This is when the largest part of the baby's head is entering the pelvis first. So therefore, it creates less room for that baby to come down. So that slows fetal descent. If the head isn't flexed enough, and the woman isn't contracting enough, it could contribute to this as well. So contractions play a big role in how that baby is going to descend properly in the pelvis. Male position, 25% have this occiput posterior. There's other, breech is the other most common one too. You don't need to know the different types of breech, but breech is more common in multifetal as well as preterm labor. High risk for a prolapse cord when you have a breech, maybe because remember that picture of station, if things aren't well applied to not only the cervix, but at that station, if you're laying breech, that cord kind of goes down. Breech is a big reason why a prolapse cord could happen, which we're going to talk about that. Face and brow presentation, it doesn't really happen as often. Sometimes it's just the way it is. Okay. CPD, again, is another, the large baby, malpresentation, slow labor progress. That's one of those. Now, the next thing we're going to talk about is a shoulder dystocia, which is an obstetric emergency where the fetal head is out and the shoulders don't deliver. So when we talked about the descent is obstructed, so as we talked about the cardio movements, remember how we go, when I said the baby's head comes out and then I said it aligns the shoulders? So that's kind of like what's happening here is either the posterior or the anterior shoulder gets stuck, okay? We are seeing this so much more, and I think the reason why is because we have increased birth weight due to gestational diabetes. that is uncontrolled. It puts both mom and a baby at risk. But there is two things that nurses do. Now, there's many maneuvers that happen in fact, we have a simulation, and when we were out on COVID, we had this simulation that it showed all the different types of maneuvers that happen. But for nursing, there's two maneuvers that we do, and that is the McRoberts and the suprapubic pressure. The McRoberts is where we put the head all the way back, the legs go all the way back, as far as they can go onto mom's, side, and then suprapubic, so it's above the pubic bone. So what you're doing is you're pushing in the direction above the pubic bone to the way the baby is facing. So if the baby is looking this way, you're going to push this way. If the baby's looking this way, you're going to push this way. So you're going to push down and over, however way the baby is looking. It is thought that could release one of the shoulders, and therefore you can get the baby out. It is, like I said, it is an emergency. People ask, can you push the baby back in and go for a C-section? And yes, you can. That's kind of like a last effort that we do, and that's called the Zavanelli. But that is not anything that nurses do. Nurses do the McRoberts and the suprapubic, and it's best to remember that. The other emergency, there's a number of them, but prolapse cord. A prolapse cord is where the umbilical cord comes below the presenting part. It can be either occult, which means hidden, or it can be frank, which is seen. Okay, you have to always assess this baby's heart rate after range of motion. See, I did it. Rupture of membranes, because fetal hypoxia can happen immediately. And basically, if you are checking a cervix and you feel something pulsating, you need to lift that presenting part off the cord. Now, you're going to see in your book, put them in knee chest, put them in Trendelenburg, wrap, a warm saline cloth around it. You're in the hospital. Basically, you just need to keep that head off of the cord, or the presenting part off of the cord, until you can get to the operating room and they remove that baby. So literally, you are always, with your hand inside, lifting that presenting part off of the cord. That is it that we do. One of the biggest reasons why a prolapse cord happens is because we break water at a high station, or there's that breech presentation is another thing. A small baby is also at high risk for that as well. Okay, so that is prolapse cord and shoulder dystocia, which are two of our emergencies. Induction and augmentation of labor. Induction means we're starting something from scratch. Augmentation is what we do for the person who has that dysfunctional labor that we just mentioned, that hypotonic uterine dysfunction. That person's in active labor, so you're augmenting, so you're jump starting something that had already started. And that's what augmentation means. There's many ways that we can induce a mom. But we're going to talk about the reasons why we would want to get somebody delivered. And you can see it in your PowerPoint, the reasons. Like, there's for somebody who has hypertension, whether it's gestational or preeclampsia. If mom has diabetes, we want to get them delivered a little bit sooner than later. The IUGR that you see is intrauterine growth restriction. So basically, if you remember when we discussed antepartum, when we talked about, a baby is going to grow as long as the placenta is healthy. So there's something going on with the placenta that this baby isn't growing. That's why you check that the fundal height in antepartum, just to see how is that baby growing appreciably. Okay. Previous history, if they have a previous history of a stillbirth, we try to get them in a little bit earlier, but not too early, just so that, because sometimes they're just so nervous. If they've had a history of a precipitous labor, we want that a little bit more controlled. The most common reason why somebody would come in for an induction is post-dates. And that's not like if your due date is today and you come in tomorrow. It's like at 40, getting closer to 42 weeks. Elective inductions happen. They're not really recommended, but they're happening more and more for a lot of reasons, but they can't happen until you've reached 39 weeks. Now, contraindications to any type of induction is really anything that's going to not deliver vaginally would be contraindicated. So if you have a placenta previa, and I know we haven't covered that, that's when the placenta is covering the cervix. If you have a cord prolapse, what are you going to do is keep your hand in there for hours, so that's not going to happen. Unstable lie, so that baby that's in that transverse lie, or breech. We don't induce breech presentations. If they've had a previous classical uterine incision, so that means not so much the skin incision, but actually a classical, a vertical incision into the uterus, because the main part of the integrity of the uterus is inhibited because of this incision. So they do not labor. Non-reassuring fetal heart rates is kind of because sometimes we kind of do it if we're worried about them, but yet the baby hasn't been stressed, so it's kind of like it declares itself a little bit. Active HSV, which is herpes. If there's any type of lesion, we go for a C-section for that, or any type of bleeding that we're unsure, we don't know where it is. That baby needs to be out sooner than later. The next slide is talking about the Bishop score, and this is a score that we use that shows the inducibility of a cervix. The higher the number, the better the induction will go. Okay, so a score of 8 or higher indicates a successful induction is likely, and less Pitocin would be needed. So you can see that there's different factors on here. We look at cervical dilatation, we look at effacement, we look at station, we look at how does the cervix feel, and its position. So remember how we talked about, like in the beginning, before you're in labor, the cervix is long, thick, closed, and posterior. This is kind of like what they're checking. So does it feel firm? Is it closed? Is it posterior? So the lower the number means that cervix needs to be ripened, okay? And that brings us to our cervical ripening agents and who can be ripened. So you might have seen already, and you'll probably start seeing it in when you're at the hospital. People have Foley bulbs or Cook's catheter, and what it is, it looks like a Foley, and it can you put it in through the cervix, so almost like through just a little bit open. You can get that in there, and what you do is you blow up the balloon like 30 to 60 cc's, and you put tension and tape it on the mom's leg, and it's said that it falls out when it's about 3 centimeters. So that's some of the things that we can do for people who can't have chemical ripening agents. Like, for example, somebody who's had a C-section, and I'm not talking about classical, I'm talking about the regular transverse C-section. They cannot have medication to ripen their cervix. It has to be mechanical. So that means like a Foley catheter bulb. Okay. You see laminaria and Lamisil. They're actually like, seaweed type of material. They absorb water and they swell and they gradually dilate the cervix. Misoprostol is actually used for the treatment of peptic ulcers, but it's also used in early abortions, but it's also used for cervical ripening, and the dose is obviously different. ACOG and AWHONN, which is our governing boards in our specialty, support its use. So, oxytocin is that hormone that's produced in the posterior pituitary gland. We talk about it with breastfeeding, that when a baby suckles on the breast, that it stimulates Pitocin. So again, one of the biggest things that you need to worry about, and you need to remember this, is uterine hyperstimulation, because what happens is this is the synthetic form of oxytocin, obviously, though it's Pitocin. It causes the uterus to contract. Well, sometimes, and that's why we go up very slowly. We put it in the closest port to the IV, because it's only maybe starting at 1 cc an hour, so you don't know. And so basically, we look for uterine hyperstimulation. And remember, the biggest stress on a fetus is contraction. So you don't want too many contractions, and you have to remember about that most important rest period in the contraction cycle. So again, there's risks in anything you do. Anytime you get that you're not spontaneous, there's always an increased risk for that hypertonic uterine activity. There's an increased risk for cesarean section, because if a baby doesn't recover. Uterine rupture, especially if you've had a previous C-section, we call that let's say you've had, like I had a C-section for my first child, and then I had a vaginal delivery for the second. So I was what they call a TOLAC. That's a trial of labor after cesarean. Well, because I delivered vaginally, I had a vaginal birth after cesarean. That's called a VBAC. So once you have a uterine scar and you're starting Pitocin, you're causing that uterus to contract, not naturally. it increases the risk of a uterine rupture. Now, it usually doesn't happen after one. It may happen after several, where the uterus gets really thin after constant, stretching and then going back and stretching. The use of epidural anesthesia is a little bit, we get that a little bit earlier. So again, that the cardinal movements of labor are affected because, you have to you can't get up and walk. So you got to kind of turn and position in the bed. And then there's more NICU admissions with inductions, and that's just because of, again, it's not natural, it's not spontaneous, but very rare unless there's something going on with this kid. We've talked a little bit about amniotomy already. This is another way of getting labor going, is the artificial rupture of that amniotic sac. It's usually performed in conjunction with induction and augmentation. The uterus collapses with the loss of amniotic fluid, so the area of placental attachment shrinks. So that's kind of like one of the things that we want to make sure that you always have a ripe cervix. If you break your water spontaneously, that's a different story, because it's kind of like the chicken and the egg. And we talked about this in class. What comes first? Do you break your water and then you start contractions, or do you start contractions and then break your water? Everybody's different, okay? But if we're going to use breaking somebody's water as a means of induction, we're going to wait until the cervix is a little bit more riper, because then that Bishop score is going to be a little bit higher once that cervix is better, okay? The risk of breaking somebody's water is we just talked about, is the prolapse cord. It introduces infection, so the longer you rupture, the chance of getting an infection is greater. There's also a risk of the placenta abrupting, which is very rare on an amniotomy. But remember the acronym COAT, C-O-A-T. So in addition to, the heart rate, you want the color, the odor, the amount, and the time. Once the water breaks, we want it, because of the increase of infection risk goes up, we want to make sure that we are taking mom's temperature every 2 hours. And again, just comfort measures, because she's leaking fluid, so you might want to put a towel in, maybe wear pads, whatever. So again, remember, it changes the environment of this kid, so you need to check the fetal heart rate. Make sure who's at risk for, why would a prolapse cord be at risk for this? So remember, position, station is really important when you're breaking somebody's water. The last couple things we're going to talk about is operative deliveries, and that means either with forceps or a vacuum. And the indications for both of them are very similar. With a vacuum, it's vertex. With a forceps, you can do any type of presentation. But one of the indications really is second stage dystocia, meaning so like if mom is just cannot push anymore and the baby's low enough, maybe we can help her out. She's exhausted, she's not pushing effectively, or maybe there's a maternal cardiac condition where she can't push, or maybe the baby's having some fetal, non-reassuring fetal heart tone, so we got to get that baby out a little bit sooner than later. But you have to make sure that that baby is low enough, and that's what the physicians have to figure out, if it's safe to get that baby out that way, or we have to do a C-section. So obviously, we worry about lacerations and hematomas of the vagina with any type of operative delivery. So one of the things in your postpartum assessment, which you're going to learn here in a little bit, is that when you have somebody, a mom who's had a baby, and she's feels like this intense pressure and pain, the worst pain in her life, which shouldn't be after delivery, you need to get down there and take a peek and make sure that there's not a hematoma, which we will talk about because it's pretty painful. And also, mom can be hemodynamically unstable because she's bleeding into this. You might have a baby that's bruised. You might have laceration marks. You might have a hematoma or a caput secundum. There might be some facial lacerations and abrasions. There could be the Bell's palsy or any type of nerve issue with the constant pulling. So you want to be careful with that. So there is a lot of factors that are very important that happen with any type of operative delivery with forceps or vacuum. So other than that, I think that is it for this one. See you in class.